Hi, welcome everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Mass General Cancer Center, which is part of our Mass General Cancer Center Genetics series. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so they can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located in the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-host and guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey that we'd like to ask you to complete. Your feedback is helpful to us as we plan future programs. So next, I am going to hand it over to Devin Punch. She is the health educator for Mass General Cancer Center, and she will introduce you all to today's guest speaker.
Thank you, Amy. Thank you, everyone, for joining us today. And a big thank you to Kristen Shannon for being here and presenting. Kristen is the director of the Cancer Center Genetics Program, a senior genetic counselor, and a professor at the MGH Institute of Health Professions. She received her bachelor's degree from the College of Holy Cross and her master's degree in human genetics from Sarah Lawrence College. She's been a practicing genetic counselor at Mass General Cancer Center in the Cancer Center's Center for Cancer Risk Assessment since 1997. Thank you so much, and I turn it over to you, Kristen.
Thank you so much, Devin and Amy, for that introduction. It's great to be here with you all. Today, I'm going to give a whirlwind tour to cancer genetic testing and go through the different types of testing that are available and the reasons why it's important to distinguish between all of them. So first, I have no financial interest that will affect this, the talk that I'm going to give. And so today I'm going to start off with just a very basic introduction to cancer genetics, just so that we're all on the same page. Then I'm going to walk through the clinical genetic testing that's available. Typically, these are tests ordered with a medical professional in the process. Also going to talk a little bit about DIY or do-it-yourself genetic testing that is available, and talk about how patients can access that type of testing and what the implications of those tests are. So just by way of background, all cancer is genetic in nature. So what that means is that it is changes or mutations in the genes in a cell that can lead to a malignancy. And so in this diagram, these circles here represent individual cells in an individual body. What happens is a mutation happens in a gene, which causes that specific gene to stop working. And then that cell remains healthy, but over the course of time, if other mutations in that same cell happen, so here's one cell where a second mutation has occurred, and then another cell where a third mutation has occurred, and then in that same cell, if a fourth or fifth mutation occurs, then that is a cell that's going to replicate, divide, and cause a cancer growth. The remaining tissue around this cancer will be healthy, but if it's these changes within an individual cell that make that cell kind of grow, divide out of control into a cancer. So while all cancer is genetic, only about 5 or 10% of cancer is hereditary. So what that means is that there are individuals, about 5 to 10% of people with cancer, that are born with one mutation in every single cell of their body. So they're already one step closer to developing a cancer in their body. So if a person is born with a mutation in every single cell of their body, it only takes 1, 2, 3 additional mutations for a cell to turn into a cancer cell and cause a tumor. So as you can imagine, people that are born with a mutation in one of these cancer predisposition genes, they are more likely to get cancer than a person that has 2 normal working copies. And they are more likely to develop their cancer at a younger age for the most part, just because they're already one step down that path. So does it matter? And yes, it does. So, and this is when we're going to get into the nitty-gritty of genetic testing. But when we do genetic testing, the testing can be done on the genes in the tumor itself, and that can help doctors and nurse practitioners and other allied health professionals to help manage that cancer and to treat that cancer with things like chemotherapy. Looking at the genes in the rest of a person's body is often not that helpful in treating that cancer in terms of treating it with chemotherapy, but it can guide a person's medical management going forward. So let me tell you a little bit more about how that works. So in terms of clinical genetic testing, so these are tests that are typically ordered by a genetic counselor or a physician or nurse practitioner. They fall into 2 different camps. So the first kind of camp are the tests that are done on the tumor itself, so on the cancer itself. The tumor is removed from the body, either with a biopsy or with surgery, a more extensive surgery, and it's analyzed for genetic mutations. And like I said, the slide before, based on what the genetic profile looks like in the cancer, a physician can make decisions about what types of chemotherapy would be best for that person to treat that cancer. And then it also can help determine eligibility for clinical trials. The other type of testing that we often talk about in the clinical genetic setting is something called germline genetic testing. So this germline genetic testing is examining the genes that are present in every cell of a person's body. So this is more global than just the tumor. Typically, we do this by obtaining either a blood sample from a person or a saliva sample, because the blood or the cheek cells that are in the saliva are generally representative of what is present in every person's body. When we do a germline genetic test, again, that doesn't tell us that a person has cancer. It just tells them what their genetic makeup is before the cancer has developed. In some cases, it can help guide chemotherapy and eligibility for trials. It can also help determine surgical interventions that might want to happen. And I'm going to talk a little bit more distinctly about that in one of the cases that I'm going to present to you in a minute. The other thing that germline genetic testing can tell us is how likely a person is to develop another cancer. So this is not, this type of testing would not tell you how likely a person is to have metastatic disease or when the cancer spreads or aggressive cancer. It really just tells how likely a person is to develop a second or a third, another totally different cancer than the person has right now. So because of that, we can when we know that a person is at risk for specific types of cancer, the medical professionals can guide their management. So they can order more screening for an individual. Say, for example, a person had a significant risk of developing thyroid cancer. They would get more rigorous thyroid cancer screening. The goal of that is to detect a cancer at the earliest stage possible, when the the treatment is more straightforward and hopefully curative. And so that's what germline genetic testing is in terms of the treatment of the individual. Germline genetic testing can also give a lot of information to family members. So if someone is born with an inherited mutation in every single cell of their body, they most likely inherited it from one of their parents. And so for that reason, that person's brothers and sisters or siblings or their children or their aunts, uncles, cousins, grandparents, all of those individuals also may share that same gene mutation that puts them at risk. And so for when a person undergoes germline genetic testing, we often will have them share that information with other family members so that they can also benefit from genetic testing. So as we walk through each type of test, I'm going to kind of give a quick overview of some examples, and then I'm going to walk you through a patient scenario where that testing was utilized. So to start off with in the clinical genetic testing space, we're going to start talking about somatic or tumor testing. So remember, this is the testing that's done on the cancer itself. There are many different companies that offer this type of testing. At the Mass General Hospital, we do have an internal lab that does some of this testing, and the lab, the test name is called snapshot testing. But you can also order these tests like Oncotype DX or MammaPrint or Foundation One or Guardant from outside genetic testing companies. And again, this is looking at the cancer itself. So a portion of the cancer would be sent to one of these labs where the testing is done. So this is an example of how that type of testing can be helpful. So in this case, Rob is a 63-year-old man that came in with a persistent cough. He reported that he smoked cigarettes socially in college, and when he had a chest x-ray, it revealed a mass in his lung, which was biopsied and revealed non-small cell lung cancer. He was worked up to see how advanced the cancer was, and he was found to have stage 4 disease, which is the most extensive disease. And so his physicians talked with him about chemotherapy options and which types of chemotherapy might be appropriate for his treatment. In terms of his social background, he is married and has 2 sons and 1 daughter. And when he looked at his family history, there were no other individuals anywhere in the family with any types of cancer. So his physicians ordered the tumor testing on his lung cancer. And what they found was that his EGFR gene was overrepresentative. So EGFR is a protein that is normally found in cells. But when there is too much EGFR protein, it leads to very rapid and much more extensive cell growth. And so finding out that Rob's cancer had an EGFR mutation in it meant that we knew definitively that he was making his cancer only, not his regular, not every other cell in his body, but his cancer was making too much EGFR. And his doctors were astute enough to say, well, there is a specific chemotherapy that can work really well when a person their tumor is making too much EGFR. So his physicians talked to him about going on an EGFR tyrosine kinase inhibitor, which is a type of chemotherapy that is quite effective in individuals that have lung cancers that overexpress EGFR. This, again, was a test that was done on the tumor itself. This was only represented in his tumor. It was not present in the rest of his body, widespread. So in terms of future cancer risk, we didn't have anything to guide us. And it was not appropriate for him to have his family members undergo this type of testing because, again, this was a unique mutation that was present in his cancer only. The second kind of group of clinical genetic tests that are often offered in the clinic are the germline tests, which again are done on blood or saliva most often. So these are not done at MGH. They are almost always done in an outside genetic testing lab. Some of the labs that we use are in Ambry, Invitae, GeneDx, Myriad, Natera. And then there's about 20 different labs in the United States that offer hereditary cancer genetic testing. Each lab has its own number of genes that they offer in terms of a test. So when we talk about genetic testing, we're most often not looking at one individual gene, we're looking at a bunch of different genes or a panel of different genes. And so each lab has its own unique panels that they offer. And there are upwards of 85 different genes that we can now test for that are specifically associated with cancer genetics. So for an example of an individual that underwent germline genetic testing, this is Beth. And so Beth is a 45-year-old woman that was recently diagnosed with a stage 1 breast cancer, which is a very early stage breast cancer with a very good prognosis. She was diagnosed and was trying to decide whether or not to have a lumpectomy or a mastectomy for her treatment of her early stage breast cancer. And she was struggling with this. When she came into her physician's office, she had told her physician that her paternal aunt was diagnosed with breast cancer and died at age 50. And none of her maternal relatives had cancer. Beth had one daughter and one son. So when Beth came in for this, she was really interested in how aggressive she needed to be from a surgical standpoint. And so we discussed germline blood genetic testing for her in light of her early age of diagnosis with breast cancer, as well as the fact that she had an aunt with breast cancer. So we drew her blood, send off the testing to the lab, and the results indicated that Beth had a BRCA1 pathogenic variant or mutation. Pathogenic variant and mutation are words that are used interchangeably. So what did this tell us? So first of all, the fact that Beth was born with a BRCA1 pathogenic variant is overwhelmingly the biggest reason that Beth has developed this breast cancer. She was born with a predisposition. She was already one step down that road towards a breast cancer. And so we've explained her breast cancer for the most part. We also know that individuals with a BRCA1 pathogenic variant are at risk for a second primary breast cancer. So typically that's in the other breast. And that number can be as high as 40%. So we talked to Beth about the fact that now that we have explained her breast cancer that she has now, but looking forward to the next 20 years, she has a 40% chance of developing a second primary breast cancer. We also talked with Beth about ovarian cancer because BRCA1 pathogenic variants increase the risk of a woman developing ovarian cancer in her life. And this number can be as high as 60% in their lifetime. We also talked about male breast cancer and prostate cancer as cancer risks associated with men. And pancreatic cancer can be slightly higher in BRCA1 mutation carriers. So after talking with Beth about these risks, she was considering how to treat the current breast cancer. And so Beth decided that she was going to have a mastectomy to treat her current breast cancer, to not only remove the tumor, but also to remove all of the healthy breast tissue to reduce the risk that she would develop a second breast cancer. And Beth also opted to have her other breast removed, again, to reduce the risk that she would develop that second breast cancer in her lifetime. We also talked to her about prophylactically removing her ovaries, and that surgery is called a bilateral salpingo-oophorectomy. So once Beth had recovered from her breast cancer surgery, she underwent bilateral salpingo-oophorectomy to remove her ovaries, again, to reduce the risk that she would develop ovarian cancer in her lifetime. The germline genetic test also gave Beth some powerful information for her relatives. So remember, she had a daughter and a son. And so since we knew that Beth had one pathogenic variant in BRCA1, each of her children had a 50-50 chance of carrying it. And her sister also had a chance of carrying it. And when we did genetic testing for the family, her daughter tested negative for the BRCA1 pathogenic variant, which was terrific news for the daughter. That meant that we had explained why Beth developed her cancer. It was that BRCA1 pathogenic variant. And we knew that her daughter did not share that same genetic variant. So her daughter had just a general population, not an elevated risk of developing breast cancer. So that was great news for her daughter. The other thing is that because her daughter did not carry this pathogenic variant, she could not pass it on to any children that she had in the future. Beth's son did not undergo genetic testing. He didn't feel like it was going to change anything in terms of his clinical management at this time. He's a pretty young guy. He was only 20. And Beth's sister underwent genetic testing, and her sister actually did carry the BRCA1 pathogenic variant. And she decided to undergo oophorectomy, again, risk reducing ovary removal. And she is being screened aggressively for breast cancer. She did not choose to have her breast removed. She decided to go with more intensive screening for breast cancer. So she's getting breast MRIs every year. There's now a second example that I want to walk through that brings both of these, the tumor genetic testing and the germline genetic testing, kind of together. So this is Florence, and she is a 55-year-old woman. She was recently diagnosed with ovarian cancer. She had surgery and is currently undergoing standard treatment chemotherapy, and she's responding well to treatment. So there's a couple of things that we wanted to talk with Florence about. So first was we wanted to look at her tumor to see if the genetic signature that's present in the tumor could help guide her chemotherapy decisions. But we also wanted to talk to her about germline genetic testing. So again, blood genetic testing, because that is standard of care for all women with ovarian cancer. All women with ovarian cancer should consider germline genetic testing because roughly 10% of them will have a germline mutation that has familial implications as well as individual implications. So Florence's test came back, and her ovarian cancer, it was found that she had a BRCA2 pathogenic variant. So in the tumor itself, there was a BRCA2 pathogenic variant. So this was helpful information in terms of guiding her chemotherapy. But the question was, did this BRCA2 pathogenic variant arise in the setting of a normal kind of genetic background? So did Florence have no mutation in all of the cells of her body, and just in one cell that BRCA2 pathogenic variant arose, which gave rise to the cancer? Or was she in fact born with this BRCA2 variant in all the cells of her body? And the difference being that if she did not have it in all the cells of her body, her risks of cancer, of developing a second cancer in the future, would not be any higher than anybody else. And if she did not have this BRCA2 pathogenic variant, she wouldn't have to worry about her children inheriting it, for example. But if she did have this BRCA2 pathogenic variant that was present in all the cells of her body, it would have familial implications and individual implications for her future risks of cancer. So when we did the germline genetic testing, it actually indicated that she did have this BRCA2 pathogenic variant in the germline, which means in her blood cells, it was in all the cells of her body. So again, for Florence, we have explained the largest contributing factor as to why she developed ovarian cancer. We also can tell her that she has a significant risk of developing breast cancer in her life, and that number can be higher than 60%. And then the implications for men in terms of male breast cancer, prostate cancer were discussed for her male relatives, and pancreatic cancer can also be slightly elevated in BRCA2 carriers. So we talked to her about that. So when all of this genetics information came back, met with Florence, and we found that her father recently was diagnosed with pancreatic cancer at the age of 78. She had one brother, one daughter, and one son. None of them had any kind of cancer. So we wanted to then figure out for Florence whether or not she had inherited this BRCA2 pathogenic variant from her father that had pancreatic cancer, or if she had inherited it from her mother. And we found out that her father did carry this BRCA2 pathogenic variant. And that was important because in BRCA2 families that have germline mutations, we will screen them for pancreatic cancer if there is a family history of pancreatic cancer. So that meant that Florence had to undergo, or was given the option of undergoing, pancreatic cancer screening. If her father had tested negative for the BRCA2 variant, we would say that his pancreatic cancer was not at all related to the BRCA2 pathogenic variant, and Florence did not need to undergo the pancreatic screening. So Florence is a great example of how all of this clinical genetic testing can come together. So the tumor testing that was done on her tumor helped her physicians determine that a PARP inhibitor, again, which is a chemotherapeutic agent, was an appropriate chemotherapy decision to make. PARP inhibitors have been shown in women with ovarian cancer associated with BRCA2 to be quite effective at treating them. We also talked to Florence about enhanced breast cancer screening, which is a little bit similar to what we talked to Beth about in her family. We talked to Florence about pancreatic cancer screening as well. And then in terms of the family workup, again, I told you already that the father had tested positive, and that's how we figured out that Florence did need pancreatic cancer screening. And Florence's daughter did test positive as well. Her son tested negative. And because we were able to identify that Florence inherited this BRCA2 pathogenic mutation from her father, her paternal relatives, so her aunts, uncles, and cousins on that side, were informed of this information so that they can get genetic testing if they wanted to. Okay, so that is the whirlwind tour of clinical genetic testing. Now I'm going to move into another type of testing that I am, to be candid, less familiar with, because this often does not involve a healthcare professional. We've called it do-it-yourself genetic testing. So this is when a patient wants to get genetic testing outside of the hospital, the clinical environment. And so there's two major buckets of do-it-yourself genetic testing that can happen in this cancer space. So the one bucket is called the direct-to-consumer testing. And these labs, examples of these labs include 23andMe, Ancestry.com, Helix has some tests. These are tests done for patients, and a healthcare professional is not involved. This is something that the individual does on his or her own, or their own. They typically look at ancestry, genetic traits, and sometimes they look at disease risk. Most often they are self-pay, so they do not go through health insurance. And for the most part, these tests are mostly for entertainment, or some have called it gene-tertainment or gentertainment. They are not intended to be used as a clinical test. The other types of do-it-yourself genetic testing are the consumer-directed genetic testing. So these include labs like Color, Sema4. These tests are actually clinically grade tests. So they are done in a clinical approved lab. They are initiated by the patient. So the patient calls the company and says, I want to get this test done. A healthcare professional does need to be involved because this is a clinical grade test. It does not need to be that person's primary care physician or anyone involved in their care, but a clinician does need to be involved in the testing to sign off on it. And so it does not have to be within their healthcare system. But these are clinically directed tests. A healthcare professional is involved, but they are often consumer or patient initiated. So the difference in terms of the technology is that in the consumer directed testing, which again are typically clinically grade tests, they are almost always gene sequencing, which is the current kind of gold standard of care for hereditary cancer genetic testing. The ancestry and the other gendertainment type direct to consumer tests do not do the gold standard type of testing. They use these things called SNPs, which is genetic markers throughout the gene, but it is not a clinical test because it doesn't meet that high standard. Using, SNPs in the direct-to-consumer world can give you risk stratification. So it can give you some background information about how likely you might be to develop a disease, but it really is not a diagnosis. And this is just a repeat of what I just said. So many SNPs are linked to disease, but they might not directly cause the disease. And normal test results do not, when you look at SNPs, they do not, if you have a normal SNP profile, it doesn't mean that that person is never going to develop a cancer. And that is in contrast to the consumer-directed testing or the clinical grade testing that is offered at some of these labs, where if individual is identified as having a germline pathogenic variant, that is a clear indication that that person has an increased risk of disease. So one example of a consumer-directed testing is Color, and this is a lab where they have a gene panel. So there's 30 genes that are tested for on their Color extended test. It includes genes that are associated with hereditary cancer as well as hereditary heart disease. And there's some genes on this panel also that can help direct patients' medical response or medication response. So in terms of the process of most consumer-directed genetic testing labs, including Color, the patient orders the test online, answers some questionnaires. They get sent to an independent physician or a genetic counselor approval. If they don't want to use their own, if their independent physician, their primary care physician doesn't want to be the ordering physician, they get sent to an outside independent contractor. And this is to ensure that the correct test is ordered and ensure quality of the genetic testing. And then the testing is done at the genetic test laboratory called Color. And then the results go directly to the patient. And then the lab offers genetic counseling if the patient wants it. So again, this is, in general, it's clinical grade testing. It is a very good test that can be used to make medical decisions. There's some limitations in the testing in terms of the scope of the testing and the sensitivity of the testing, but it is a pretty good test and one that is often used in the clinical setting. So to show an example of an individual that underwent Color testing. So Carol is a 28-year-old woman, and she's curious about her health history. She doesn't have any family history of cancer. Her best friend was recently diagnosed with breast cancer though, and she was becoming more anxious that she too would develop breast cancer. And she was very concerned about privacy concerns in the medical records. So she decided that she wanted to initiate a color consumer-directed genetic test. She paid for the testing out of pocket and did not use her own PCP to order the test. And Carol, when her test results came back, it was found that she had a pathogenic variant in a gene called RAD51C. So RAD51C is a well-known, well-characterized gene that puts an individual at risk for ovarian cancer, mostly. And it can increase a woman's risk to greater than 10% of lifetime risk of developing ovarian cancer. And the risk of developing breast cancer is also slightly higher than most women. So Carol was a little anxious about this because the risk of ovarian cancer is quite high. She did not have cancer, so there was no treatment-related decisions that needed to be made. But we did talk to Carol about undergoing risk-reducing ovary removal. The current data about this in RAD51 carriers suggests that surgery doesn't happen, and it doesn't have to happen or is safe. She's safe until she was age 45, and then at 45 is when we suggest that she consider this surgery. So she had plenty of time to consider having children or reaping the benefits of having natural estrogen in her body. The difficult thing came when Carol wanted to consider this surgery, because many insurance companies need to have a diagnostic reason why you're undergoing risk-reducing surgery. So we did tell Carol that when it came to that point, she may have to tell her insurance company that she had this RAD51C mutation in order for them to cover the surgery. So that was something that was very concerning to Carol because she was so concerned about the privacy regulations, but we spent a lot of time talking to her about the fact that the surgery was super important to do in terms of keeping her healthy and reducing her risk, and that this information, when it's in the medical system, is private, as all medical information is. And there are also, fairly good laws that are in place in terms of healthcare insurance discrimination. So most healthcare insurance companies cannot use genetics to discriminate. So in terms of Carol's, the implications for her family, it did have reproductive implications. So Carol had not had children at this time, but we told her that if she did have children, she would have a 50-50 chance of passing it on to any children that she had. When we worked up the family, Carol's father actually tested positive. Her sister was negative, so her sister did not need to worry about ovarian cancer risk any more than anybody else in the general population. And Carol told her paternal relatives, because again, her father tested positive for this pathogenic variant, told the paternal relatives, so her cousins and aunts and uncles, that they should consider genetic testing. So the last kind of bucket of information I'm going to review, and this is definitely, I'm not an expert in this, again, because this is direct to consumer testing. This is, for the most part, ancestors. There's two types of testing that you can do. You can, a patient can initiate a test and get just ancestry information. There are some labs that do both ancestry information and risk stratification for specific diseases. And so 23andMe is an example of one of these labs. And 23andMe does offer some ancestry information, but also some health risk information. And on this slide are some of the genes that are included, or some of the SNP testing that's done in that space. You'll recognize that there's a couple of hereditary cancer syndromes that are addressed on this test. One is BRCA1 and BRCA2, which we've talked about before with a couple of case examples. It's important to recognize, however, that this 23andMe test only looks for 3 specific mutations, and those 3 specific mutations are more common in the Ashkenazi Jewish population. So if an individual undergoes this 23andMe test and is not Jewish and they are negative, that's really no information at all for them. There's another kind of cancer predisposition gene called MUT-YH associated polyposis that's also addressed on this panel. These are the 2 common mutations in that gene. So just wanted to talk a little bit about direct-to-consumer testing. So these, again, remember, these are tests initiated by an individual themselves, a patient themselves. There's no medical professional involved. And there was a study done a couple of years ago that highlighted the fact that these tests were not clinical grade testing. And it showed that there was some false positive test results in this space. And so of the 49 people that participated in that they looked at in this study, 40% of them had a false positive on some of the direct-to-consumer testing. So if a person undergoes one of these direct-to-consumer tests and gets a positive test result, it's super important to follow up with their doctor, genetic counselor, healthcare professional to make sure that that's an actual, and have it repeated in a clinical setting so that it can be confirmed. And again, I'm going to skip over this, that slide, sorry about that. It's important when you're looking into direct-to-consumer testing to read the fine print. So these tests are suitable only for research, education, informational use. And in all of the handouts or all of the kind of buyer beware statements that are on all these direct-to-consumer tests, it's pretty clear that they are not to be used for medical or diagnostic use. So again, this speaks to the fact that if you want to get information that's helpful in your medical care, it's best to go with a clinical grade testing and not with one of these tests. The direct-to-consumer tests are certainly interesting, and they can, be interesting in terms of ancestry information and other health risk information that might give you some information to help you eat better or diet more, but they really are not supposed to be used as clinical information. The other thing about direct-to-consumer tests that individuals should be aware of is that they can often release your personal health information. So as you can see in this statement, the company says that they are likely to use or disclose your personal health information for the following purposes. And there are a handful of information, including sharing genetic information with their business associates. So it's just something to consider before going into a direct-to-consumer test, that by ordering that test or by giving your saliva to that company, you're kind of relinquishing all control of your genetics information. And so this is my last example of a patient who had a direct-to-consumer test. So this is Melanie. Melanie is 30, and she had a mother and a maternal aunt with breast cancer, and she was really interested in health and ancestry. And so she went out and she bought a 23andMe direct-to-consumer test kit. Melanie's results came back and indicated that, she, in terms of health-related risks, so again, this is a SNP, not clinical driver test, that she was at average risk for most big health diseases that it tests for, and that she was reassured to realize that she did not have a BRCA1 or BRCA2 pathogenic identified on this 23andMe test. So she was great. She then, shortly afterwards, found a lump in her breast and went to a surgeon to have it worked up. And then when the surgeon worked her up, she wasn't very concerned about the lump in Melanie's breast, but she said, why don't we consider referring you for further risk assessment, because you do have a mother and a maternal aunt with breast cancer. So Melanie went to see a genetic counselor and had germline genetic testing. And Melanie's test results came back that she did have a pathogenic variant of BRCA1. So remember, this is, and this specific mutation or pathogenic variant is not one of the Ashkenazi Jewish founder mutations. So the DTC test was accurate. It was not inaccurate. She did not have one of those 3 mutations, but because the DTC test was not a complete clinical grade test, this mutation was missed. And so again, Melanie, we talked a little bit about BRCA1 before, but she had an increased risk of both breast and ovarian cancer. So in terms of her personalized plan, we talked to Melanie. She did not have any treatment decision to make because after further working up the lump in her breast, it was determined to be a benign cyst. So she did not have to make any treatment-related decisions based on this. But we did talk to Melanie about cancer risk management. And so she is getting much more intensive breast screening now. She undergoes mammograms every year as well as a breast MRI, and she's seen by a surgeon twice a year. And we did talk to her about having a risk-reducing salpingo oophorectomy to dramatically reduce the risk of her developing ovarian cancer. So in terms of working up her family, we wanted to give the information to her family as well. Her mother had passed away, so we were not able to test her. So we tested Melanie's father, and because Melanie's father did not have this BRCA1 pathogenic variant, we presumed that the mother gave it to Melanie. Melanie's siblings were tested, none of them had it. And this is a typo, this should say the maternal relatives were informed of the information because again, the father tested negative, so it was not lurking on his side of the family, it was lurking on the mother's side of the family. So we notified the mother's relatives. Okay, so in the interest of time, I'm going to just wrap up here and just offer a couple of take-home points. So I hope that I've given some background and shown you that there are various options for cancer genetic testing, and there's a lot of different options in this space. Not all genetic tests are created equal, and it's really important to understand the nuances of each of them. I also think that, it's important to look before you leap, or consider all the testing implications and what the information that you're about to sign up for is going to return to you so that you don't have any surprises. And I also want to just say, ask questions of your providers, ask questions of your genetic counselors, ask your providers to refer you to a genetic counselor. If you're pursuing direct-to-consumer testing, ask questions, read more about those tests, and before you just kind of go ahead with it, you have a full understanding of all the privacy regulations and the powerful information that can be obtained through these tests. And this is my contact information. I'm happy to answer questions. You can reach out to me at my email address or at my direct line. And I think that will wrap up my portion. I hope we have enough time for some questions.
Thank you so much, Kristen. Looks like we do have some questions coming in. Do you have similar slides on the ATM genetic mutation? It was nice to see the BRCA1 and 2 slides.
Yes. So we do have charts, and I assume you're talking about the charts that talk about the specific cancer risk. We do have them available for ATM. We have them available for most of the hereditary cancer genes that we talk about. They are on our website through the MGH/CCRA, and they're available in multiple languages as well. But if you want me to specifically get them to you, whoever asks the question, feel free to email me or give me a call and I can get them to you directly.
Thank you. And for everyone, I did enter the website for the Center for Cancer Risk Assessment in the chat, so it's there.
Thanks, Devin.
A couple more questions. One about testing on prostate cancer. I had foundation 1 testing for prostate cancer, and it showed that I had a variant in a gene called PTEN. Do my children need to be tested for this?
That's a great question. So Foundation 1, taking you back to the very beginning of this talk, Foundation 1 is a type of test done on the tumor itself. So the prostate cancer itself has a mutation in PTEN. That test does not determine whether or not it's present in the germline or not. So PTEN is a commonly mutated gene in many different types of cancer. I can say that it is very unlikely to be present in the germline, but I can't say for sure. So I would suggest, if you're very concerned about it, ask your doctor, see if he or she or they think that a referral for germline genetic testing is indicated. But given the information just on the tumor itself, that doesn't tell us anything about how likely your children are to have that gene mutation. So they don't need genetic testing at this point.
How old does your child have to be to get testing?
That's a great question. So it depends on which gene is involved. Most of the cancer genes that we talk about in the hereditary setting are considered adult onset conditions in our genetics world. And there are, for various reasons, many of the larger academic statements have come out and said that germline genetic testing for adult onset conditions is not recommended in children. So for that, because it's not going to change their clinical management at all before they're 18. So usually genetic testing of this type is reserved for people 18 and older. 18 tends to be the magic age that they turn into a miraculous adult. I think, there are exceptions to that rule. There are some genes that we test for that do predispose to childhood onset cancers. Those are pretty rare though. So in those cases, we would test younger children. But I think in general, 18 is a good benchmark.
Thank you. I had ovarian cancer 2 years ago, and my doctor ordered genetic testing. How do I find out what type of testing was ordered and what the test results are?
That's a great question. So the best way to figure that out is to actually go back to your physician that ordered the testing and ask to see a copy of the test report. So 2 years ago, it could have been that the tumor was sent to a lab and that test result came back, or it could have been that the doctor ordered a germline genetic test, or it could have been both. And so I think the best way to do it is to call the doctor or the healthcare system, ask for the genetic test results itself. I think if you are specifically a patient at Mass General Brigham in our cancer center, all of our test reports are available through Patient Gateway, so you can find it there. And if you need any help finding that, you can reach out to your genetic counselor that you saw or your physician. But if you were not seen within the Mass General Brigham system, you would it's probably best to go back to the doctor that ordered the testing.
Thank you. A couple more questions, and we do have a few more minutes. So if there are any more things that you'd like to ask that haven't been brought up, feel free to type in. I know someone that did an ancestry test, came back with results of Italian and Greek ancestry. About 6 months later, the company sent them a new report saying that they were Italian, Greek, and Egyptian. What is up with that change?
That's a good question. Again, I am not an expert in this ancestry space, so I want to just kind of be transparent about that. But because the information and the data that these companies are collecting is getting bigger and it's getting more and more data together, they are refining their kind of geographic placements. So based on their data can change and their interpretation of the data can change. So I know that it's not unusual for a person to have their initial report say that they are X ethnicity and then have it change later. It's very likely going to change even more in the future as we get more and more data about ancestry and these SNPs and how they pan out. So it doesn't mean that they were wrong at first. It just means that the data is now ripening and more information is getting taken in, and they're refining. They're getting more accurate, I guess is the best way to say it.
Can clinical and/or consumer-based DIY genetic testing affect health insurance or life insurance coverage? Will results be reported to one or either of those?
That's a really good question. So, and I think it depends. Okay, so, and I'll preface this with I'm not a lawyer, but there are very good laws in federal and state laws that prohibit health insurance companies from using this information, even if they get access to it. Okay. Life insurance is totally different. Life insurance companies do not have any laws that say that they can't use this. So the question, I guess, is, how is a health insurance company or a life insurance company going to get access to this information? Okay. So if you go the consumer directed route, the information does exist. It does not exist in your medical record. So if you were to sign off a release that your health insurance company can look at your medical record, it's not going to be in there. But if the health insurance company or if the life insurance company directly asks you, have you had a genetic test and what were the test results? It doesn't matter where that information is. If you lie to them, that's fraud. So even if you get testing from an outside company that does not disclose, it doesn't put the test results into the medical record, and they don't disclose directly to life insurance company, it's still possible that you might need to disclose it. In my understanding, and again, this is when reading the fine print is really important. My understanding is that if a health insurance company pays for the genetic test, they can request the results. If they do not, they don't even know that it's run, right? So it's important for you as an individual to reach out directly to the testing company that you're going with and ask them specifically what their policies are, who they're going to release this to, what your ethical and legal obligations are to disclose the information before you do it. It's really it's independent lab specific. That was a long-winded answer for a very one statement that I could have made. Sorry.
No, thank you, because I'm sure there's lots of facets within that people aren't even thinking about up front. So thank you. Looks like that is actually all the time that we have for today. Thank you everyone so much for joining us. Kristen, do you have any final parting words?
No, thank you. It's been wonderful being with you today. Thank you to the Blum Center for hosting these, and thanks to Devin as well.
Great. Thank you, everyone. Enjoy the rest of your day. Bye-bye.